My guest today is Dr. Grant Pagdin, and Grant is a functional medicine practitioner who's doing some very interesting and important work in the regenerative medicine space. He is in British Columbia, Canada, and is currently running a study that is dealing with osteoarthritis, and he has about 147 patients that he's able to report on with different joints involved, including knee, ankle, hip, shoulder, CMC joint in the hand, and his data is very compelling. We talk about that as well as some of the other things that he thinks is so important in expanding lifespan and improving health span. So I think you'll enjoy this conversation because it covers a lot of basics that always need reinforcement. So please enjoy this conversation that I have with Dr. Grant Pagdin.
Welcome to the Pod of Inquiry. Ready for some thought-provoking cerebral whipping and the destruction of ridiculous medical dogma? Want to shift those stale, moldy old paradigms? Well then, don that thinking cap of yours, get down in the cave, and join our host, Dr. Stephen Barrett, for this week's episode. Let's start spelunking.
Welcome to the Pod of Inquiry, everyone. The podcast for human optimization and understanding, and nothing fits so well with that mantra than my guest today, Dr. Grant Pagdin. And Grant, tell everybody where you're from. We chatted a couple of weeks ago. You got some really cool, interesting things going on, and I think we're very synchronous on our wavelengths about longevity and health span and all of the cool things that are going on. So tell everybody kind of where you're from and what you're doing, and then we'll get into some cool stuff.
Thanks very much, Stephen. It's an honor to be on your show today. My name is Grant Pagdin, and I'm working in a town called Kelowna in central British Columbia. We're about 4 hours north of Vancouver. It's the third largest city in British Columbia. So we have a catchment area of in the ballpark of 200,000 population in this vicinity. So my practice is focused on anti-aging and regenerative medicine. So I'm interested in optimal aging, hormone replacement, weight optimization, but my main focus really is the regenerative stuff. So I'm working with platelets, with peptides, and also with stem cells.
All right. So we had talked, and you said you had a pretty interesting study that you've been conducting or were involved with on osteoarthritis. Was that just of the knee, or was that of multiple joints?
So it's all the peripheral joints.
Okay.
So I treat shoulders, elbows, wrists, hips, knees, and ankles, all the major peripheral joints. And as you might be aware, the regulatory environment in Canada is a little different than what you're faced with in the US. So I started doing work in the stem cell field back in 2013. My mentor back in those days was Dr. Joseph Purita out of Boca Raton, Florida. Right. And so he kind of got me started with the basic skills required. In 2013, there was no sort of regulatory oversight in Canada, and a number of providers in Canada started doing this kind of work. But then in 2019, what happened is Health Canada issued a sort of a moratorium on any stem cell work, insisting that these biologic substances were now going to be labeled as drugs. So in order to use these for the treatment of any medical condition, we had to either file a new drug application, which is very expensive, right, or file a clinical trial application and get it approved by Health Canada. So fortunately for me, I was in a good position. I had done a bunch of pharmaceutical company-sponsored clinical research. I had my name on about 35 different projects up to that point. So I kind of understood what clinical research was all about. I thought it couldn't be too hard to design my own project. But it was a little bit of a challenge. I was back and forth with Health Canada for about 6 months to try and get my project approved. I got the no objection letter from Health Canada at the beginning of 2020. I got approval from ethics the following month. And then, of course, we had COVID in March, and so everything was shut down. So we didn't actually enroll our first research subject until September of 2020, when we could sort of get back to face-to-face medical treatments. So the project is designed with 3 treatment arms, and subjects are randomly assigned to one of 3 potential treatments. They're either going to get a combination of PRP with lipoaspirate or PRP with bone marrow aspirate, and the third group gets PRP with a combination of both lipoaspirate and bone marrow aspirate. So my hypothesis in designing the trial in this way was that I had hoped that perhaps the combination of all three ingredients might have superior outcome to just using either of the stem cell sources alone. So to this stage in the trial, we've enrolled, I think it's 147 as of last week, out of a total of 240. And over the past few years here, we've been able to observe that about 2/3 of all of our patients are achieving what we would consider to be a clinically meaningful improvement in their pain and function, with no appreciable difference between the three treatment groups, interestingly. So my hypothesis hasn't quite borne out. It looks like all of the groups are doing equally well. It doesn't seem to matter which group they get assigned to. So,
well, that's interesting. If they have virtually equal results, then you would probably gravitate to something that might not involve the bone marrow aspirate, because that's a little bit more invasive to get that versus the PRP with the lipoaspirate.
Yeah, there's pros and cons, you know. We find that when the subject has to participate in both types of harvesting, the fat and the bone marrow, I always ask them at the end of the case, which one did they think was worse? And it's interesting, the majority will say that the fat harvesting was actually worse than the bone marrow harvesting.
Interesting.
You know, and from my point of view as well, Stephen, the fat harvesting is a little bit tedious. You know, we infiltrate a whole bunch of what we call tumescent fluid into the area. We let it set for a few minutes, about 10 minutes or so. And then the harvesting, I use a tiny little aspiration cannula. It's about 2 millimeters in diameter. And I'm moving that through the fat tissue plane, you know, multiple passes, to try to aspirate an adequate volume of lipoaspirate. The difference with the bone marrow is I have a very sophisticated type of trocar that allows me to aspirate all of the bone marrow I need from a variety of depths with one single poke through the periosteum. So as long as the periosteum is adequately anesthetized, I tap my trocar through the cortex of the bone, advance it into the bone marrow, and then I rotate the instrument and gradually withdraw sequential fractions of bone marrow aspirate. And then by rotating this instrument, I can aspirate stem cells from a variety of different depths in the bone marrow. So I'm not pulling up a whole bunch of venous lacunar blood. So it's one simple poke. It's a 3 or 4 minute procedure to withdraw the bone marrow, and then I give the instrument one final twist. It falls out. We put a little Band-Aid on, and we're done. So the bone marrow is actually very much quicker, less labor intensive than the fat aspirate. So the disadvantage to bone marrow is that I think that the quality and the numbers of stem cells gradually decline with age in the bone marrow, but it hasn't been shown to be the case so much with lipoaspirate. So in an older population, we would prefer the lipoaspirate versus the bone marrow aspirate. In a younger person, it's really, you know, it comes down to their individual preference, really.
Well, I would think, you know, I've had a lot of patients complain about post liposuction neuropathies, and you know, no matter who the surgeon is and how good they are, you're still tearing up a lot of small little nerve branches in that area, and some of them are anesthetic forever after that. And so yeah, I guess from a post-procedure aspect, I would see that would be a disadvantage versus the bone marrow aspirate. But I guess with the smaller cannula and the way you're doing it, you know, obviously there's lots of esoteric ways to do things better. And it sounds like that's what you've done with the bone marrow aspirate.
Yeah, it's quite a nice cannula. This comes from a company called Servos. And so they produce a very sophisticated bone marrow aspirate trocar. But you're right, though. I do sometimes get the complication of some surface anesthesia around the area that we made our incision for aspirating the fat. but because there's a little bit of trauma to some of those superficial nerves. So what I find is gradually the area of numbness shrinks, over subsequent, 12 to 18 months. There may be a little bit of residual numbness left, but typically people are quite happy to tolerate that. I aspirate the fat from the flank region. My understanding is that the quality of the stem cells is a little bit superior if we use post-axial fat rather than pre-axial fat. That was the feeling of Dr. Purita, anyways, when I was mentoring with him. And lots of people come to me and say, "Hey, could you take the fat off my belly?" Well, we can take it from anywhere, really, but I prefer the post-axial fat, so the flank region, the kind of the love handle is a target.
Right. Then they're going to come back and want the other side done so that they have
symmetry. So it evens out.
Right?
Yeah, exactly. So, well, I take a relatively small volume of fat. I'm going to take about 40 cc's of fat, right? Okay. So it's not a huge volume. And I infiltrate with about 120 cc's of tumescent fluid. It's got some epinephrine and some lidocaine in it. Minimize the bruising. Right. And of course, I don't want people on a blood thinner for about 48 hours prior to their procedure. We have done it on rare occasions, somebody that wasn't medically capable of
getting off
terminating their blood thinner medication. Right. But then we wrap them up with a bunch of tensor bandages and, put some ice on it and so on right away to minimize the bruising. But, they go a little bit black and blue.
Okay. So now you've aspirated it. You've got your magic potion for a way to look at it. How do you administer it? Intra-articular or subchondral?
So yeah, it's intra-articular, ultrasound guided.
Okay.
I've only done the subchondral injections when I was down at the Regenerative Institute in Colorado. They're set up with fluoroscopy, and so I did their advanced knee and hip course. I was able to do some intraosseous injections under fluoro guidance. But in my office, I just have ultrasound. So I'm strictly intra-articular, but then we also will use some of our PRP for some of the supportive structures and some of the ligaments and so on, stabilizing a joint, especially if those seem to be additional pain generators. So essentially the stem cells will be injected intra-articular, PRP as a chaser, and then some additional PRP if required to some of the extra-articular supportive structures.
And then what about weight bearing and activity? What's your protocol from?
Yeah, we have standardized exercise handouts for each of the joints that we treat. Mm-hmm. I don't like to immobilize the joints. I like to get people moving as soon as possible. So the first instructions are around just range of motion for the first couple of weeks. Then they can gradually start to add some resistance. So we like the TheraBands and resistance bands and so on. The only caution is against weight bearing, percussive, high impact activities. Yeah. Okay. So if it's the lower extremities, it's running and jumping. If it's the upper extremities, it's things like hitting a baseball, hitting a golf ball, chopping a cord of wood. Those things we would hold off on, and really for 6 or 8 weeks ideally, because we know that the stem cells can actually survive in the joint for up to 12 weeks.
Wow. Okay.
So I do get the patients to come back in 4 weeks for a top-up injection of PRP and another 4 weeks for another top-up injection of PRP. So some of the studies that have done these PRP follow-ups have shown slightly superior outcomes to the studies that have just done, one single injection and off you go. So our protocol involves the 2 follow-up injections of PRP. Not everybody's doing that, and there's certainly not really a consensus in the literature that that's how it ought to be done, but that's how we set up our protocol.
Now, what about selection criteria? Because, you can have some folks that, they're literally bone on bone, and then there's other folks that still have relatively marginally good joint spaces, but how do you determine who's a fit and who's not?
Sure. So I have treated patients with Kellergren-Lawrence grade 4 osteoarthritis. So as you described, there's virtually no cartilage left, bone on bone. The bones are starting to actually deteriorate, right? So those folks that would not be eligible for a surgical joint replacement because of other concomitant medical illnesses, we will still offer them a stem cell treatment. They're not eligible for the clinical research package. But, I have had some reasonably good outcomes with elderly folks with bone-on-bone osteoarthritis that had no nowhere else to go. For the clinical research project, though, it's anywhere from Kelligren-Lawrence grade 1 to grade 3. So we will treat, moderately advanced osteoarthritis as long as there's a little bit of cartilage there.
Okay. Very, very interesting. And your follow-up now, did you tell me you had 2 years of follow-up?
Yeah. So my primary endpoint is really at 12 months. And what we find is that people are already starting to do reasonably well by 6 months, but we're getting slightly better scores at 12 months than we are at 6 months. So we're thinking that probably the kind of the optimal window for recovery is somewhere around the 6 to 9 month mark. And the thing Health Canada wanted us to include the 24-month time point really just as a safety check to make sure that nothing bad was happening to these people. They're not developing tumors in their joints or anything peculiar going on with regard to the stem cells. So really the 24-month follow-up, the main emphasis there is safety. So we're finding our sort of peak efficacy is at around 12 months. And then the great thing is it doesn't seem to deteriorate. There's hardly anybody where it drops off after 12 months. If they're good at 12 months, they're typically good at 24 months and well beyond. So I've had some people now that I've treated before I launched my research project, treated back in the 2016, 2018 era. They're still doing well, and some of those folks are calling me up now and saying, hey, it feels like my stem cell treatment is starting to wear off a little bit. Do you think I could come back and have some more? And then if they're eligible, they can come into the research project at this point.
Now, you said you did multiple joints. Do you have any comparisons? Because I would presume that there are some joints that are more responsive because of the different types of biomechanical stresses that are put on them. Like I would think that the ankle joint and the knee joint would be very, I shouldn't say very, but more difficult maybe than upper extremity, shoulder, and because just weight bearing phenomena. Is that anywhere close, or what's your experience?
Before we continue with this great discussion, I just want to take a quick break to acknowledge this week's sponsor.
I'm constantly exploring new avenues to enhance well-being and address any health concerns. Today, I'm thrilled to introduce you to an exciting supplement called Stem Regen, which I take daily and genuinely believe could revolutionize your health journey as well. Stem Regen stands out as a game changer in the realm of wellness. Crafted from 5 potent plant extracts, it boasts a remarkable ability to stimulate the release of your body's own stem cells from your red bone marrow. Why is this significant? Well, stem cells are the superheroes of our body's natural repair system. They possess the extraordinary capacity to morph into various cell types, aiding in tissue regeneration and repair. As we age, the quantity of circulating stem cells in our system reduces significantly, impairing our body's ability to heal and rejuvenate itself effectively. Stem Regen steps in to counter this decline by kickstarting the release of stem cells into circulation, thereby bolstering your body's innate repair mechanisms. Once unleashed into your bloodstream, these mobilized stem cells actively seek out areas of damage or injury, initiating the healing process. By incorporating Stem Regen into your daily routine, you're essentially empowering your body to tap into its own regenerative prowess more efficiently. I firmly believe that Stem Regen could be a valuable addition to your wellness regimen, especially if you're seeking to fortify overall health and vitality, accelerate tissue repair, or expedite recovery from injury or illness. This first of its kind stem cell mobilizer is changing the game in regenerative medicine. Don't wait to unleash your body's innate healing capabilities. Visit stemregen.co/Dr. Steven, that's with a PH, and use the code SBPOD to get a 15% discount off your first order of Stem Regen. Hey Spelunkers, we're thrilled to kick off Season 6 with a fresh new look and the most exciting content we've ever delivered. This season, we're diving deep into the fascinating world of human optimization and understanding. But wait, there's more. We're giving back to our loyal listeners with an exclusive giveaway each and every episode of Season 6. That's right, prizes are waiting just for you. So how can you join in on this fun? Well, it's simple. Follow us on Facebook, Instagram, and LinkedIn. Subscribe to our YouTube channel, and here's the magic touch. Comment, "Let's Spelunk on any of our Season 6 YouTube videos to enter. Of course, please add anything else you'd like to your review. Don't miss your chance to explore, learn, and win with the Pod of Inquiry. Let's spelunk into the wonders of Season 6 together.
Yeah, so that's a really good thought. And so we will be doing a subgroup analysis and separating out our upper extremity from lower extremity, to really sort of tease out that if there is a discrepancy there. My overall kind of clinical impression at this point is I haven't noticed a tremendous difference in the outcomes between upper versus lower extremities. Ankles are a little difficult to treat, but we have had some good success with fairly severe ankle arthritis. One that we do tend to get particularly good results with is the first CMC joint at the wrist. And that's probably the third or fourth most common place that I'm injecting. It's a super common place for osteoarthritis, and people tend to get quite good results. We can't get very much volume in there, of course, because it's quite a small joint. So we're giving a modest dose of our biologics, and people seem to do really quite well with first CMC. The most common joint we deal with is knees, followed closely by hips, and then third is probably shoulders. Fourth would be first CMCs.
Interesting. Yeah, I mean, from a post-operative recovery standpoint, outcomes, it seems to be like total knee arthroplasties and ankle joint replacements are very, very high on the complication, chronic post-surgical pain spectrum, versus hips seem to do, people do really well, and especially now with the minimally invasive procedures and, anterior approaches. But
absolutely. They're ambulating the same day. It's like a daycare surgery now, Stephen, and they're going home the same day, ambulating comfortably. It's really amazing.
Yeah, it is. I was playing pickleball the other day with a guy that just had a hip done like literally 6 weeks ago. You would never notice that he had anything done.
Wow.
Phenomenal.
Yeah.
So if people want to reach out to you, are you still enrolling patients or not?
Yeah, we are. Like last week, we just rolled subject 147. We've got room for 240. And because I haven't yet been able to tease out a difference, I'm thinking I may actually extend the trial for another 120 subjects for a total of 360. So I just have to put in a protocol amendment, get Health Canada to give us the blessing, and then we run that past ethics. So I'm going to be enrolling subjects for the next couple of years. Now, our study is confined to Canadian subjects. I'm not sure how many Canadian listeners you have on your podcast, but Canadian subjects between the age of 19 to 79 with osteoarthritis in any one of those major peripheral joints. And it should be symptomatic for at least a few months leading up to enrollment. If their pain score is like a 3 or 4 out of 10, that's ideal. If the pain score would only be 1 out of 10, the problem is that my cutoff for a clinically meaningful outcome is the pain score needs to improve by 2 points or greater. So if they're coming to me with a pain score of 1, well, I'm not going to achieve it. Even if I get the pain to 0, I can't really call that clinically meaningful. So, some sort of mildly disabling level of pain is what we're looking for a few months leading up to it. We do a CBC, so we want to make sure that the hemoglobin is over 100 and platelet count is over 100, and then we're good to go.
And what about any other selection criteria or exclusion criteria? What about like if they're smokers or?
There's a couple important exclusions. We don't want to be treating anything that would be considered an autoimmune condition. So if the person has some degenerative arthritis, but they also have psoriasis or lupus or some other connective tissue disorder or inflammatory bowel disease that could have joint manifestations, we exclude the autoimmune diseases. So we're trying to deal with just pure osteoarthritis. And the second important exclusion would be any active cancer. Now, we don't think that stem cells have any direct relationship with cancer. There's been a number of really excellent long-term safety studies with thousands of patients to indicate that stem cell treatment doesn't have any impact on incidence of cancer. But a patient with active cancer would be excluded.
Now, it's interesting you mentioned that, because when I talked, I had Bill Lawrence on bioregulatory peptides, and that's one of the exclusions in his studies, is that they could never have a cancer diagnosis or have a current diagnosis. But I've talked to other folks that have pretty pretty good knowledge of Cavinson's work and everything. And it turns out that these folks believe that there might actually be indications for the bioregulatory peptides.
For bioregulatory peptides, yeah. I have a patient right now that's stage 4 colon cancer, and he is exploring some of the bioregulatory peptides that have anti-tumor activity. So the one specifically for colon cancer would be Vilon, but we also like Epitalon, Thymolin. There's a couple of those peptides that I think have anti-cancer potential. And if the person is stage 4 cancer, they're pulling out all the stops. So what do you have to lose?
Yeah, and it's sometimes things are counterintuitive. And I think where a lot of the fear is that, oh, God forbid you exacerbate somebody's cancer, right? I mean, that's where where that's come from. But when you look at the bioregulatory peptides and what they're doing, and I don't know clearly enough about cellular metabolism from an oncology standpoint and everything like that, but these are substances that appear not to be high risk based on conversations.
I would agree. I would agree with that assessment. Yeah, for sure.
So,
we can be reassured. We can be reassured with regard to the stem cells in cancer with a couple of excellent long-term safety studies. So one of the pioneers in this field is a guy from France called Philippe Hernigau.
Oh, yeah.
And he's great at using bone marrow aspirate in the hips, particularly for avascular necrosis. But he produced a paper, it's got to be, 15 or 20 years ago now, where he followed over 3,500 patients for 10 years to make sure that they had no increased incidence of cancer, not just in the treated joint, but anywhere else in their body. And he was able to demonstrate there was no increased risk of cancer. And the other big long-term safety study was Chris Centeno's group from Colorado, the Regenerative group. And he produced a paper showing, I think he followed over 1,600 patients for between 5 to 10 years, again, showing no increased risk of cancer. So I think we've kind of laid that one to rest.
I haven't heard Hernigau's name for a long, long period of time, but he published a very interesting study or clinical case studies where he was able to revascularize folks with significant peripheral arterial disease using different types of, I think he was using at that time mostly PRP.
Right.
But it was like, and he had the venograms and the angiograms to show this, and it was like, that's pretty objective. You know what I mean? It's not like that's I feel 7 out of 10 versus a 9 out of 10. This is like,
right.
This is saving their extremity. And he's like basically giving them a new plumbing system.
It's pretty amazing, really, what we can get out of the platelets,
Yeah.
So one of the questions that Health Canada asked me was, how are you going to actually prove that you have made some improvement to the articular cartilage? Can you do an MRI before and an MRI after? Well, yeah, we could do that. But, here we're faced with, in the public health system, cost containment issues, right? So if a person wants to go and get a private MRI, that's available. A private MRI costs approximately $1,000 Canadian. So if I required my research subjects to go and have a pre-treatment MRI and then a post-treatment MRI about 9 months later, I'm adding an extra couple $1,000s to the cost of the project. Now, there's no independent funding for my project. It's not like any sponsor has given me millions of dollars to conduct the study. So the patients that participate have to pay sort of what I think is a relatively modest fee to cover the costs of these interventions, and to ask them on top of that to also pay for an MRI before and after, it just wasn't going to be practical. So I said to Health Canada, listen, I'm going to do some functional outcomes in terms of pain and well-being and the impact of the arthritis on various aspects of life, social activities, recreational activities, sleep, and so on. And those are going to be my outcome measures. And they felt that was adequate. I guess aside from a high resolution MRI, the only other way to look at the cartilage is to actually go in there with a scope, and take pictures or take biopsies. And we just didn't want to be doing anything invasive like that. So the people that do respond well, they have significant improvements in pain and function, back to doing activities like running again and things that they had given up, sometimes for a number of years before having an intervention. But we've also been quite impressed with the longevity of the benefit as well, stretching out, 3 to 5 years and beyond.
Right. Well, if someone gets 3 to 5 years, that's going to do a lot for them, not only from that joint, that single joint or multiple joint perspective, but now they're actually able to do the activity that they want to do. So you have positive emotional benefits from that. I mean, you take somebody who's into one particular thing for a long, long period of time, and you take that away, that has tremendous psychological ramifications for a patient. And then those other, there's carryover into, how much exercise they're able to do. So it fits in the whole longevity. One of the biggest interrupters of health span is getting injured. It's like, if I can prevent injury, that's one of the pillars of trying to stay healthy.
Absolutely. Yeah, for sure.
But no, that's very interesting. So you started out, you told me, as family practice, right?
Right. Yeah. My background is family practice, board certified. Then I specialized in emergency medicine, focused on that for a few years.
Right.
And then just really decided to kind of get off the sort of the public healthcare system, the insurance system in Canada, and moved into sort of more private consulting around optimal aging. So, we do a pretty good job, I think, of disease management, but we really don't do anything in terms of preventative health, nutrition, counseling, weight loss, or any of those kind of things. They're just not covered by the public healthcare system.
Right.
So folks that are motivated to age optimally, are quite happy to engage with a consultant like myself, in terms of just tweaking and optimizing, because they want to age optimally. They don't want to be getting frail and decrepit and slower and fatter and weaker and all the rest of the things that go along with that can go along with aging.
Well, in that model that you left, there's no space for doing what you're having to invest from time and education and all of these other things. And so the system can't, the way the system is designed, and I don't know I really don't know much about the Canadian healthcare system, but I can tell you the American healthcare system is pretty wrecked. And, people are running on this treadmill to see their 70 patients that day. Well, hell, they don't have time to ask somebody about what may be contributing to their problem. It's just like one disease, one drug, or maybe two drugs, and one orthopedic condition, and here's 2 or 3 surgical options, and get out, because I got to get to the next room. Yeah, exactly. Yeah. And it's a system that's tremendously broken, and I don't see it getting fixed real soon.
It's exactly the same thing that we're faced with here. So I just wanted to get off that treadmill, right?
Yeah.
So I see maybe 8 or 10 patients a day. On a procedure day, I might only see 3 or 4. If I'm doing procedures Mondays and Wednesdays, and I'm doing my consulting on Tuesdays and Thursdays. So, I have a relaxed pace. I have plenty of time with my patients. They can have, up to 45 minutes for an appointment, ask all the questions that they want. Whereas in family practice, you're only allowed one question. Okay. You got more than one question, book another appointment, right?
Yeah. Wow. So let's talk about some of the other cool things, and not to mitigate the coolness of what we just talked about, but what else are you finding that is one of the hot buttons now in your practice as far as trying to optimize these folks? Is it the bioregs, or what are you dialing into?
We're doing a lot of PRP for sports injuries, and we're trying to amplify the benefits and the recovery with some of these experimental peptides. I know your listeners are going to be familiar with things like BPC-157 and TB-500. I know you've had a number of podcast episodes around those kinds of guys. They're gaining some traction and kind of being reasonably well adopted in the sort of regenerative medicine community. But there's a few other kind of newer ones on the market. One that we like to add for joint treatments is a peptide called Cartilax. It's available by injection. And then we also use some of the growth hormone releasing peptides. So things like CJC-1295 with ipamorelin. We're getting pretty good results with that. We track people's IGF-1 to sort of see what the clinical response is. And those kind of things can very much amplify the benefits that we're getting with PRP for sports injuries.
And now a message from our sponsor.
The power of ketones, your body's alternative fuel. The folks at Approved Medical Solutions have done it again. That's right, with their new Clean Ketones supplement. Imagine your body as a hybrid car capable of running on 2 different fuel sources. While glucose is your body's regular gasoline, ketones are like switching to an efficient, clean-burning alternative fuel. I would say rocket fuel. When your body produces ketones, whether through fasting, low-carb dieting, or intense exercise, something remarkable happens. These molecular powerhouses cross the blood-brain barrier, providing crystal-clear mental energy that many describe as enhanced focus and clarity. But ketones aren't just brain fuel. They're efficient energy sources for your heart, muscles, and other vital organs. Think of them as premium-grade fuel that produces less metabolic waste than glucose processing. Research suggests ketones may offer additional benefits: reduced inflammation, improved metabolic health, and even potential neuroprotective properties. They're particularly interesting for athletes seeking sustained energy and anyone looking to optimize their cognitive performance. The best part? Your body is naturally designed to produce and use ketones. It's not about completely replacing glucose, it's about metabolic flexibility, giving your body the ability to thrive on both fuel sources. Whether you're interested in mental clarity, athletic performance, or overall health, understanding and harnessing the power of ketones might be your key to unlocking new levels of well-being. Approved Medical Solutions Clean Ketone Formula contains nature-identical ketones. These ketones provide the same fuel as those produced through a keto diet. Approved Medical Solutions Ketone Formula does not contain sugar, caffeine, or 1,3-butane-diol, and they are not ketone salts. I've been using them routinely now and notice a minimum of a 10% increase in exercise performance. By diving deep into cutting-edge research and real-world applications with leading scientists and practitioners, the Pot of Inquiry illuminates the science-backed path to enhancing your mind and body's potential. You can find us on all platforms, including Spotify and Apple Podcasts. Please join us. Are you dialed into anything from Christian Drapeau, the STEM Regen guys?
No, that's not something I'm too familiar with.
He's got a fantastic product. Basically, what it does is the adult stem cells are sequestered in the bone marrow, and as we get older, that marrow shrinks, right? But there's still a lot of sequestration, and he has some natural supplements that will actually allow to get these cells out of the sequestration from the bone marrow and circulate. And I've had probably about 3 years of experience with this, and I've seen it in patients where we would do a lot of nerve decompressions that were bilateral. And so the first one, we hadn't adopted the STEM Regen protocol, and then put them on, and then their second surgery, and they're coming in and they're saying, my incision healed so fast on this, and look, it's not raised or anything like that. And I take it every day myself because it just makes a lot of sense. But that might be a good augmentation to all of the things that you're doing, because now you're actually being able to pull those stem cells out into the circulation. They do their deal, and then they go back into their resequestration. So it's not like you're losing anything. So you check it out. It's really fascinating
absolutely
stuff. Yeah,
but that does sound fascinating. Yeah, any way that we can kind of mobilize those guys and get more of the messengers out there is going to be really important. So we do add a few kind of nutritional things to our protocol. My standard recommendation for everybody after a regenerative procedure is blueberries, green tea, and dark chocolate.
Oh,
right? So that's pretty easy.
Yeah, that's pretty easy.
Yeah, and so just incorporate those in your regular diet. Now, we also really like a product that helps to support glutathione production, because your master antioxidant is a critical part of stem cell performance, right? And so a lot of people struggle to make enough glutathione. The rate limiting component is the cysteine. So we give people a special supplement of cysteine to produce a little more glutathione, and we think that they'll do a little bit better with regard to stem cell performance. So so there are definitely some nutritional things that I think can amplify, and maybe the STEM Regen product would perhaps contain some of those types of things.
Yeah, I would encourage you to take a look at it. Christian's got a tremendous amount of laboratory data. So that it's not just like, here, take this, it'll make you feel. I mean, they have the numbers, they're actually able to measure these. And I think that I'm going to say a number, it's probably wrong, but I think that they can get about 120 million from the sequestered cells that are already there.
Right, get them out into circulation. Wow.
Yeah.
So
that's
pretty substantial.
Yeah. Now that number may be wrong. You have to go check me out on that, but it is a significant number. But it might be something that you would find interesting, because I think it ties in. And I don't know how you feel, but a lot of the functional medicine guys that I've talked to is that there is no one magic bullet, but there is multiple good stackings that
absolutely
seem so. Tell the folks what stacking, because I mean, if you think about it from a nutritional standpoint, what we do from what we eat every day is a stacking, if you think about it, right?
Yeah.
You mentioned
absolutely
the berries and the antioxidant activity. So what's your thoughts on that? I mean,
well, I think that you're exactly right, Stephen. The more different avenues we can bring to bear on the problem, the more comprehensive and holistic our treatment package is, the better the outcome, right?
Right.
So there's a lot of synergies between various interventions. Okay, so one common example that your listeners will be very familiar with is when we use these GLP-1 agonists for weight loss. Right. That it's got to be combined with protein supplementation and resistance exercise. You can't just go on the Ozempic and hope to lose your 40 pounds and be the picture of health. Right. You're going to lose muscle, right?
Yeah.
So you need to be supplementing with protein and doing the resistance exercise. We can stick PRP in a joint, but if you do the appropriate rehab exercises, maybe do some shockwave, maybe do some red light therapy, and maybe stack with some of these peptides, like we call this the Wolverine stack that combines BPC-157, TB-4, and Cardilax. You do that for 12 weeks after your PRP, you're going to do better than the person that doesn't do that.
Now, tell me what Cardilax is. Is it a short chain peptide, or what is it?
It is. It's one of the short chain peptides. I haven't seen it commercially available in an oral form. I'm not exactly sure how many amino acids, but I believe it is one of the short sort of bioregulator peptides. Okay. Now, we have a Canadian manufacturing company, and Health Canada has said if we're going to be using injectable peptides, they got to be sourced, from a Canadian manufacturer that's government certified. Right. So I have a source for injectable Cardilax. I do think that it's probably available as one of the oral bioregulators from Nature's Marvels, perhaps. Right. But anyways, this is a specific injectable short chain.
Yeah, and while it's great to be able to put somebody on an oral bioreg, it's also great to add an intra-articular or intra-tendinous or whatever. I mean, I don't have any reservations about putting somebody on oral BPC-157, but if they've got a deficit in a tendon or a fascial issue or something like that, and you can get that administered intra-substance, it seems to really be,
quite a bit more powerful. Yeah. And then that would be my clinical experience as well, Stephen. I've made the same kind of observation. Yeah.
So what else? Grant, is on the functional medicine horizon that we need to talk about? And
well, it's interesting how there's still so many of the family doctors out there that don't really understand hormone replacement, right?
Right.
And so, I'm constantly sort of fighting that battle with, trying to educate my colleagues around the benefits of these bioidenticals. Right. The office immediately next door to my office here in Kelowna is a group of OBGYNs, right? Mm-hmm. And so they're thinking I'm crazy for putting these women on these bioidentical things, right?
Right.
But really, it just makes such a huge difference to people's ability to age. Nothing good is happening in our bodies as our hormone levels decline, right?
No.
So you're going to get slower, fatter, sicker, stupider, all the rest of it, and more frail. Who wants that?
Right.
So we engage with our patients in getting their hormones balanced. For women, it's not just the estrogen and progesterone. DHEA is important. Testosterone is important. and metabolism optimization. So sometimes we'll be using peptides in combination with, a variety of hormones. And then, certain nutritional supplements to support things along the way as well, depending on the individual needs. We like to do a kind of a micronutrient analysis to identify specific areas where there may be some deficiencies.
Right.
And the company that we use for that microanalysis is great at producing a list of recommendations, including dosages of various things that you might want to tweak to your supplement plan. Make sure that you're covering all the bases. Then you recheck the micronutrients 6 months later, and everything's tickety-boo. Right. So, so I think really in terms of optimal aging, the hormones are kind of a cornerstone, right?
Yeah, and Grant, I'm sorry to interrupt you, but I just did an episode with Chris Estes, he's a board certified OB-GYN, and he's into functional medicine. I don't know if you know him. They're down in Miami Beach. Okay. And he obviously knows a hell of a lot about female hormonal systems, and consequently he's had to dive in from the functional medicine side into the male hormones. And we just had a chat talking about how important, testosterone supplementation is for males, and that it's not just a sex hormone. It's a hormone that has far-reaching ramifications, but yet there's still, and he admits it, and I have to agree that the tide has changed in thought over the last 10 or 15 years, but there's still these guys that are stuck in this old paradigm about bioidentical hormones and replacement therapy. And I think they're stuck in the Women's Health Initiative of like 2001 or 2002 that just kind of like, nobody even read the data in that thing right. And so they developed a paradigm that was just wrong. And it was like all these people, these ladies are suffering because of, some really poor interpretation of this study. That was a very robust study. And then there's the myth of, testosterone replacement in males that have prostate cancer. And that has changed tremendously. And we went back to that article, I think it was published in 1941, Huggins and Hitchens, I'm blanking on their names right now, but I think it had like 3 or 4 patients in the clinical report. It wasn't even a bona fide study, but yet that set the table for 50 years of maltreatment. Yeah.
Yeah, there's a lot of stigma around hormone replacement even today, even with all the evidence we've accumulated in the last 20 years,
Right.
But you're right, the Women's Health Initiative, good study. Like there was 16,000 women from a number of Western countries, but they were taking oral estrogen, which we know increases the risk of venous thromboembolism. And they were combining it with a synthetic progestin that doesn't occur anywhere in nature. It's hydroxyprogesterone acetate, which is not a natural occurring substance. And it was the progesterone folks, the Provera folks, that were seeing the increased risk of breast cancer, and it was the oral estrogens causing the increased risk of stroke. So the study was stopped early, and the conclusion was you need to take all the women off hormone replacement post-menopause. Now they got nothing. They could take black cohosh and ashwagandha and tough it out, right?
Right.
As long as we put the estrogen on the skin, if it's transdermal, it bypasses the liver. We don't get the increased clotting factors to increase the risk of VTE. And if we use a human bioidentical progesterone, there's no increased risk of breast cancer. So those risks have completely been mitigated. And there's 25 years of research now in the bioidenticals, right?
Right.
But the testosterone replacement is an interesting one for men because there are some caveats, right? So there's lots of guys that'll just get their black market testosterone from the gym and they're shooting up whatever and they just go kind of according to how they feel. We firmly believe, of course, that people need to be medically monitored.
Of course.
So there's 3 important things that we keep a close eye on. Not just the testosterone levels, but we keep an eye on the CBC because, you can get polycythemia, an increase in red blood cell count that makes your blood a little bit thick. So we keep a close eye on that. We also want to keep a close eye on estrogen. So you remember that paper in JAMA a few years ago that indicated that if guys go on testosterone, their increased risk of a cardiac event in the first 3 to 6 months after starting testosterone replacement therapy. It's not the testosterone doing that. it's the estrogen.
Right.
So
Right.
if you don't have any control over how much testosterone is being aromatized to estrogen, you can run huge levels of estrogen, and that's going to increase your risk. So we monitor estrogen carefully. We use small doses of aromatase inhibitors to keep it in a kind of a happy window, but I don't want to drive estrogen too low because it does have some cardioprotective effects. So just kind of keeping estrogen in a happy range is important. And then the third thing, of course, that we want to keep an eye on is prostate health. So there's no connection between testosterone replacement and prostate cancer. In fact, most of the more aggressive prostate cancers occur in men whose testosterone levels are low. Right. Morgenthaler put out a good book called Testosterone for Life. I don't know if you have a copy of it, but
I don't, but I've seen some of his work. Yeah.
Yeah. So he goes through that all quite thoroughly in terms of the risks and benefits.
Right.
It's not to say there aren't any risks. Any hormone can have a risk. Too much of a good thing is always a bad thing, right?
Right.
But although the testosterone can increase dihydrotestosterone, which can lead to problems with acne or hair loss or increasing the size of the prostate, we have ways of downregulating the dihydrotestosterone. That's the 5-alpha reductase pathway. So there are some strategies there to dial that down if it seems to be a problem.
Now, what about, you mentioned the fact that if you're on too high of a testosterone dosage, you can get the increase in the hemoglobin and the hematocrit. Can you reverse that, just getting their dosage back down, or do they need something like anastrozole or something else to?
Yeah, there's not really a specific antidote. We modify the testosterone dose, but the simple solution is just go have a phlebotomy.
Right.
So you can go to your local Red Cross and go donate a pint. Your hemoglobin comes down 10 points and you're good, right?
Yeah.
So I have some guys that are on a regular schedule of going to donate a pint of blood every couple of months. And if you can't donate to Red Cross, your hospital will do a phlebotomy and just throw it in the garbage. So, for hemoglobin higher than 200, where there's, they're really, sort of, they're red in the face, their eyes are red, their hemoglobin's really high, then I just make them go do a phlebotomy at the hospital.
Well, you do the same thing if they have a high ferritin level.
Sure, exactly.
Yeah. It's just, So makes good sense.
So that's the simple solution.
Very cool. Grant, you've given some wonderful information. I admire what you're doing, and I think we need thousands more practitioners out there doing exactly what you're doing, because you're really making a difference in people's health span and their longevity. And so thanks for coming on the show, and I appreciate it so much.
Absolutely, Stephen. Well, thanks for the time today. I'm really passionate about what I do, and I love to see people's lives transform. So it's just such a rewarding field of medicine, and something that's really needed, I think.
Oh, it is. It's super gratifying when people come back and say, "Hey, you changed my life."
Absolutely. Yeah.
All right.
Great. Well, thanks for your time today.
Thank you.
As you know, I'm passionate about learning new ways to address health concerns. Moreover, before I recommend any treatment or supplement, I always try it on myself. Today, I want to share my experience with Troche. I have investigated other phytocannabinoid formulas and found that, in general, they were not consistent or reliable in their results. What impressed me about the Troche delivery technology is that each rapid-release tab is engineered to provide fast-acting, long-lasting, reliable delivery of phytocannabinoids to support your health and well-being. Many physicians understand the importance of using phytocannabinoids for physical discomfort, sleep issues, and mood. But if the formula is not reliable, most patients will give up, never experiencing the real benefits. I put this to the test on myself and actually tracked my progress. This graph shows my results for reducing stress. Troche is so serious about how well their product works, they partnered with People Science to provide the Troche Tracker health assessment application that lets you monitor your progress and works with you to accomplish your wellness goals. If you are a patient, click the link below and the patient button to register for Troche Tracker. Assess your baseline health metrics and receive a free Troche sample in addition to getting preferred patient pricing on all products. If you are a clinician interested in adding Troche to your practice, click the link below and then the clinician button to register for a wholesale affiliate account, or go to the link above. I hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes found at our website, podofinquiry.com. If you think you might have tickled just a few neurons inside that cerebral cortex, please spread the word to your friends and colleagues and tell them that they need to get spelunking. Also, if you can take a minute to leave a review on your podcast provider of choice, and especially Apple Podcasts, that would greatly help the show and be so appreciated, provided it's positive. And if not, then just keep your pie hole shut and stay down in that cave. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.